Thank you for attending this Hot Topic session. Hot Topic presentations under the direction of MSD past president, Dr. Stephen Kushner, address urgent issues and bring important education to our members in the medical community. Questions, feel free to type them into the chat box, or we'll do Q&A after his presentation. I will let Dr. Stephen Kushner now introduce our speaker.
Thank you, Lynn. Good evening, everyone. Welcome to this evening's Hot Topic CME session. We are thrilled to have you join us for what promises to be an engaging and an informative event today. We will delve into the critical discussions surrounding occupational medicine, specifically focusing on Corian dust exposure and its implications for pulmonary fibrosis. We are honored today to have Dr. Matthew Caddell, DO and MPH, as our speaker. With nearly 25 years of experience in various clinical settings, Dr. Caddell currently serves as a staff physician at Bayhealth Occupational Medicine in Milford, Delaware. His extensive background includes work in the community hospitals, public health clinics in New York State, and academic institutions. Since 2022, he has been an active member of the Medical Society of Delaware, volunteering on Public Health Subcommittee. Dr. Caddell recently earned his Certificate of Added Qualification in Hyperbaric Medicine, COQHP, in October 2024. We look forward to Dr. Caddell's insights and expertise on this important topic. Thank you all for being here. Let's make the most of our time together.
You can't hear anything, can you?
No.
Welcome, Dr.
Yes.
Caddell.
Oh, thank you. So I'll start with the presentation. I appreciate everybody joining us tonight. I'm going to talk about a case report that I had published in the American Journal of Industrial Medicine earlier this year. It was a 12-year journey that I undertook with OSHA to get this case report published. So my intention with this is to kind of give you a feel of the case report, but I want to present some occupational medicine topics in the context of the case report. I can almost guarantee this may be the only didactic lecture this may be the only didactic lecture you ever had on occupational medicine. So I kind of want to keep it basic, but I want to show how these basic principles applied in this case. And so since I am such a Zoom novice, I'm going to ask Lynn to advance the slides for me. So Lynn, if you can.
Sorry, I'm going to stop sharing for 1 second and reshare just because it's giving us a hard time this evening. There we go. All right. There we go, doctor. I'm sorry.
Okay. So I guess that's what I'll do throughout the presentation, Lynn. I'll just ask you to, okay. So there you see the abstract of my case. And a couple of names I want you to notice there. Claudia, first off, this was a case from September 2012. Claudia at the time was a resident in occupational medicine at OSHA in Washington, D.C. Hillary Waterhouse was our representative for our local OSHA office when I was working in Albany, New York. Jerry Abraham is a pathologist. That's his team there on the second line from Syracuse. There's me, and Michael Hodson he still is the medical director for OSHA in Washington, D.C. So we're going to start with some basic questions about occupational medicine, talk about the case report, and then questions. Next slide, please. So to answer the question, what is occupational medicine? I usually like to frame it in the context of two luminaries. To the left, you have Bernardino Ramazzini. He was an Italian physician who in 1700 published De Morbis Artificium Diatriba. That's Latin. I don't know what I said, but probably was Pig Latin, but that's Latin for diseases of the worker. And it was a groundbreaking scientific work because it was the first time that occupational groups were analyzed scientifically. He looked at 53 occupations that were common in his day, to mill workers, to blacksmiths, and he noticed key exposures each one of these groups had. It was a publication that was printed many times in Europe. But the basic premise of that text was to ask your worker, patient, what type of work do you do? And that still rings true to this day. don't get caught up in a CDC 8-page survey about occupational exposures. I can guarantee your patient won't do it and you probably wouldn't understand it. But just ask the question about what type of work they do. To the right is Alice Hamilton. She was a physician in Illinois at the turn of the century, pathologist, infectious disease specialist in Chicago. She was appointed to the Chicago Workers' Comp Industrial Board in the early 20th century and did a lot of great work in occupational medicine. But what was really made her different was, as the stamp says, she was a social reformer. She noticed the socioeconomic, socio-political aspects of occupational medicine, the labor activism that still happens to this day. She was a champion and a voice for these for for workers that were under wage slavery at the time. If you ever read Upton Sinclair's book, The Jungle, you can kind of get a feel of what working conditions were like at the turn of the century. So I kind of keep these two individuals in mind when I'm thinking about occupational medicine. Ramazzini was more about the science. Alice Hamilton was about the social aspects. Next slide, please. This is just my model of it. Occupational medicine is a clinical specialty. I am also boarded in family medicine, and it has served me well in my career in occupational medicine. There's times where I feel like I'm the primary care doc for the patients I see, be that for pre-employment exams, fitness for duty, or for workers' comp cases. I would recommend to have a background in musculoskeletal medicine. For a period of time, workers' comp was referred to as the industrial athlete because there's a lot of musculoskeletal components to it. Occupational health. Think of occupational health as the public health for occupational medicine. When you're in family practice, you're thinking about, public health principles for the general public at large. Occupational health is really about public health for occupational medicine. And in this circle, I would put industrial hygienists, safety professionals, occupational health nurses, ergonomists. And at the top circle, occupational medicine is a business to business relationship that you have with companies. Companies will send to you their workers' comp cases, and there's a direct cost to workers' comp, the injury itself, and the indemnity benefits with the claim. But there's also an indirect cost. Every time an injured worker is removed off a line or put into a different position, the indirect cost could be fourfold. So I'll give you an example. If Bill is a forklift driver in a warehouse, he gets injured, the employer may have to retrain Steve or Bob to operate the forklift. The indirect costs are always much more important with the workers' comp case than the direct costs of the indemnity benefits or the medical expenses. Next slide, please. So what is occupational medicine? We are primarily a service sector economy, but there's still a need for occupational medicine. The publication to the left is from the Institute of Medicine, titled Safe Work in the 21st Century. And in this publication, they mentioned the demand and the growing demand for occupational medicine and occupational health professionals. They were projecting the need for occupational medicine board certified physicians in this country is about 3,000 to 5,000. I can tell you right now, the American Board of Preventive Medicine is nowhere near that. Currently, the residency programs probably put out 100 new residency trained physicians annually. And then with the little maps there to the right, I'm sure we all know that there are many healthcare shortages in our state due to the fact we don't have enough of primary care. It's a rural state, and there's no medical school. I know the local hospitals down here in Sussex County have started residency programs that, to start a pipeline that perhaps one day will have more providers. But in the context of there not being enough for primary care, not being enough for dentists or mental health, I'm going to put in there's not enough of occupational health professionals or occupational medicine docs. So part of this, my intention with this presentation is to kind of engage primary care docs more in the concept of occupational medicine, because we need you to be engaged, because there's not enough of doctors like myself that can handle this workload. Currently in the state of Delaware, I think I could probably count on one hand, and including myself, docs who are board certified in occupational medicine. Next slide, please. So I kind of gave you a feel for there's a need for occupational medicine. When you're doing occupational medicine, you have to know about OSHA, and I'm sure you've heard that term before. It was legislation that came through the Nixon administration in the late 60s, and Congress passed the OSHA Act in 1970. And the act applies to private industries. So if you're self-employed, family farm, small establishment, or a government worker, you're not covered under federal OSHA. But that doesn't mean that government workers aren't covered. There's different government OSHA programs and workers' comp that covers government workers. OSHA is enforceable. This is the law of the land. This is through the Department of Labor. It's not like NIOSH, the National Institute of Occupational Safety and Health, or the CDC, which are through the Department of Health and Human Services. Those are regulations, guidelines, suggestions, etc. OSHA is legally enforceable. So that means when an OSHA inspector shows up at a job site, and if an employer is in violation of several standards, there is a monetary violation, or there could be criminal charges if they're significant enough. What I want you to keep in mind is Delaware is a federal OSHA state. What that means is Delaware has adopted the federal model. About 21 states in this country actually say to the federal government, look, we appreciate your model, but we're going to do our own. And in all honesty, those are the stronger state programs. Cal OSHA is a phenomenal state OSHA program. It's the OSHA program in California. So Delaware, like the majority of the states, just decide to go with the federal model. We're under the Philadelphia Regional Office, and our office for state OSHA is in Wilmington. As healthcare workers, you've been impacted by OSHA standards and regulations, respiratory protection. If you remember during COVID, we all had to wear a mask. I'll talk more about that in a minute. Bloodborne pathogens, if you're unfortunate to get stuck with the needle during a procedure, and hazard communications. This is if you're working with certain chemicals in a lab, the employer is supposed to educate you on those chemicals. Next slide, please. So I just want to kind of just go a little off script and just talk a little bit about the nomenclature of respirators. This was a big pet peeve of mine during the height of COVID, is that everyone just thought that N95s were synonymous with respiratory protection. That is not true. These are part of the family. If you see on the slide there, it says filtering facepiece respirators. The N95 is only one of 9 in that category. The N, the R, and the P means its resistance to oil. The 95, 99, 100 means the efficiency of the filtering, the filtering meshwork within the respirator. So my point is that we talked about N95s a lot during the height of COVID, which was important, but in all honesty, you could have grabbed an R99. You could have grabbed a P100. You could have grabbed any one of those 9, and nobody really talked about that. And, I have to go off script here, but there was a lot of miscommunication about respirators during the height of COVID. People thought surgical masks were respirators. They're not. Surgical masks are approved by the FDA. Respirators are approved by NIOSH. And then people were making, taking socks and knitting respirators for themselves, or what they thought were respirators. So in my case, my worker did not have access to respiratory protection. That would have made all the difference. Next slide, please. So just a couple of tidbits here about OSHA. Applies mainly to private industry. Employers must comply with OSHA standards. Again, this is legally enforceable. This is not the CDC. This is not NIOSH. This is federal law from the Department of Labor, be that at the federal or state level. The third little bubble there, non-compliance with OSHA standards can result in monetary fines or criminal convictions. If there's no specific OSHA standard, OSHA uses this term called general duty clause. What that means is that, for example, OSHA doesn't have a standard for ergonomics, but NIOSH has plenty of literature on it. So OSHA expects the employer to follow the latest guidance from NIOSH. The problem is OSHA never enforces that. Of the violations they give to employers, under general duty, it's less than 2%. Employees are granted whistleblower protection against employers. This sounds great, but it really doesn't play out that way. And that was an issue with my worker. And this is about OSHA jointly funding state programs that wanted to establish their own OSHA programs. Again, Delaware does not do that. We have a federal model. Next slide, please. So what are the top 10 most cited standards from OSHA? This is always the same list. If you look under fall protection, it says 1926, that's general construction. We as healthcare workers are in 1910, which is general industry. Respiratory protection, item 7 is always listed. Hazardous communication is always up there for general industry. If you look at the 1926 citations, that's item 1, 3, 4, 8, and 9. 4 of those have to do about fall protection. That is a very big deal in the construction trades. So, and again, my worker, the employer did not have a respiratory protection program. And it's not a program, you just can't open up a box of respirators and tell your workers, here, just go into the box and pull out a respirator. You have to train them on it. You have to fit test them on it. They need to get medical clearance on it. It's a very involved standard. And I guess that's why it's always cited in the top 10 for OSHA. Next slide, please. So this is a great publication, and the publications I mentioned in this presentation are free. So you just Google it and you can find it. I don't take publications I have to pay for. So this is AFL-CIO, big labor union. Again, there's labor activism and occupational health. And it's a good publication to go through because they compare all the states, how each state is doing with OSHA. And again, there's some politics to their publications, but if you just kind of flip to the back of it, what you see there are hard numbers from the Bureau of Labor Statistics. And just going through our state, Delaware, number of employees, number of establishments, 40,000. State or federal OSHA program, we're a federal program. And if you look at our rates for fatalities, just to let you know, there's about 5,300 worker deaths in this country every year. That's about 15 a day. That's incredible to me. But our rates for fatalities and injuries and illnesses kind of match up with the rest of the country. So even though we have a federal program, by the numbers, we're not doing that bad. The thing that always jumps out at me when I look at this data is if you look at the number of workplace safety and health inspectors we have in Wilmington, we have 5, and we have 40,000 establishments. By the calculations, that would take OSHA, our 5 OSHA inspectors, 178 years to inspect each job site in this state. It's not going to happen. So again, that just makes the primary care doc know that there's very limited OSHA impact. And this is true throughout the country. This isn't just in Delaware. So you need to be aware of occupational medicine, and you need to be aware of the limitations of OSHA. Next slide, please. So what is workers' compensation? This is a system of no-fault liability insurance between workers and employers where tort action is exchanged for mutual protection. What that means is during the Industrial Revolution, it was a very hazardous work environment for which workers were getting injured at no fault of the employers. It was just the nature of the work. And out of that, came this concept of workers' comp. And all the developed countries at that time had a version of this. It started in Germany, then it was in England. Our model here in this country kind of adapts versions from both Germany and from England. And it was a form of legal protection. What was happening at that time, 100 years ago, workers would get injured on the job. The worker could then technically drag their employer into court and sue them for negligence under tort law. The problem with that is that's a very long process. The legal system in this country moves very slow. So meanwhile, the worker's not getting the care he or she needs. But if the worker persevered and if they got a favorable jury, there was big verdicts going to these injured workers. Businesses do not like risk. They want to understand what it is they're up against. So it wasn't working for workers, it wasn't working for employers, and hence we have workers' comp. And it started first at the federal level through the administration of Theodore Roosevelt, and it slowly came down into the states. This is the trade-off. Workers are receiving medical coverage, percentage of lost wages, vocational services, and death benefits in exchange for not suing their employers. The employers get the all-important exclusive remedy. Injured workers cannot sue their employers under workers' comp. And I see employees like this all the time, injured workers, and they want to sue for this, want to sue for that. And I'm like, you can't do that. You are here under workers' comp. That's the trade-off you just made. Now, there are attorneys involved in the workers' comp process, don't get me wrong, but employers are protected. And they're protected against pain and suffering, loss of consortium, or third-party damages. Loss of consortium means that that if Bill has a back injury and he can no longer enjoy time with his family, that means consortium. Just to let you know, pain and suffering is very much covered under federal agencies for federal workers, not so much at the state level. And this became a necessity through the Industrial Revolution. Next slide, please. So what is worker? So the employer needs to be thinking of this legal term arising out of and in the course of employment. There's a lot of case law, there's a lot of fact patterns that really define if an injury is work related. To give you an example, if Bill's walking down the hallway in his company and he sprains his ankle, that happened on the job in the course of his employment, that's covered under workers' comp. But what if Bill is now walking in the parking lot of this company and he also sprains his ankle? That should probably be covered because the parking lot should be part of the employer's premises. But what happens if Bill parked across the street, sprained his ankle, and this was no longer the employer's property? The point here is it gets very legal in trying to define which is work related and which is not. And as a physician, don't get involved in that area. That's not your job here. Jurisdiction is a very interesting legal issue. Just say if Bill lives in Delaware, he's working for a company in Pennsylvania, and the headquarters for the company is in Tennessee. Which workers' comp model is going to take his workers' comp case? A very good workers' comp attorney will figure that out for the injured worker. Obviously, the injured worker wants to be in the better system. Generally, the jurisdiction does wind up in the state where the injury occurred. Non-documented workers are covered under workers' comp. The problem is non-documented workers may not know this, and employers may not be telling them that, but legally they are covered. Independent contractors, this is a way that employers try to get around a workers' comp case. They claim, Bill doesn't really work for me. He's his own entity and he's just here doing something else. This was a big case with Uber drivers. But the Uber drivers, said they won the case, big case in California, that we do work for Uber. We're not independent contractors. Potential defenses for employers' disobedience. Employers usually have, policies and procedure manuals, and they don't expect Bill to be showing up, and I don't know, and in plate mail armor or something being goofy at work, because if he did, he would, in the manual, he would be told to go home. Intoxication. A majority of employers will do breath alcohols on their workers' comp cases, and I suspect they're trying to line up that type of defense for themselves. Horseplay, skylarking is just antics at work. Again, if someone's acting up at work, I don't know, playing football on the premises, obviously that's not behavior covered in the company policy manual, and that could be a possible defense for the employer. For the insurance company, there's this concept of moral hazard. What does that mean? That means in the workers' comp world, there's minimal moral hazard to a traumatic injury, to a laceration, to a contusion, because it's a clear fact pattern about what happened to cause the injury. The problem you have are these maximum moral hazard episodes, occupational illnesses, where the causation is a bit more opaque. There's a latency period. There could be non-occupational causes, malingering, patients act out the way they do. This was an issue with my case. The insurance company that I had to go to court for twice for my injured worker kept on pushing back non-occupational causes for his pulmonary fibrosis. So that gets a little murky. If you're just doing bread and butter occupational medicine, you're dealing with minimal moral hazard where there's a very specific incident. Soft versus hard markets. This is an underwriting metric. I have another slide on this. We are in a very soft market. What does that mean? It's a buyer's market. So that means when the combined ratio, that's CR, when it's less than 100, everybody loves workers' comp. So for every $100 that these insurance companies have taken in on premiums, they're paying out just $80. So they're keeping 20 and they're investing it in workers' comp is profitable. A hard market is when the insurance company is paying out more than what they're taking in. And I've worked through hard markets, and workers' comp is a different tone. And I'll have a slide about that in a minute. Experience modification. This is something that our governor signed the Senate bill. I know it was in the MSD letter a couple months back. I think that was Senate Bill 306, in which the state is going to help companies with their experience modification, or EMOD. So that basically means they're looking at the safety profile of your company. So when you apply for workers' comp insurance, the insurance company is going to say, what's your safety record? And that's the OSHA 300 logs. It's the same as if with your auto insurance. If you have a history of previous accidents, that's going to drive up your premium. So next slide, please. So this is just looking at the combined ratio. I don't want to get too much into the numbers. I just want to show you it's a cyclical market. Workers' comp is super duper easy to do right now because insurance companies are very profitable. I have done workers' comp through that 2009, 2012. That's when my case was. The tone with workers' comp is different. The insurance company can have occupational nurses. They can have case managers showing up for each one of the workers' visits. There's a lot of oversight, utilization review. Right now, it is really easy to do workers' comp, to the extent that there's very little oversight. You want to get an MRI of the left ankle, they'll probably pay for it. So, and as you can see from this bar graph, there has been this up and down. The other thing I want you to point out, which I find interesting, is that COVID didn't blip these bar graphs over 100. Why was that? People were working from home. You're not going to get injured at work if you're not at work. So I think from the insurance point of view, they would prefer remote work. And right now, I mean, I'm not an insurance agent, but I do read up on this. Since workers' comp has been so profiled for the property and for the property insurance companies, that they may start rolling this monoline of workers' comp insurance into auto, into homeowners insurance, because those rates are well over 100. And that may be the move on the insurance side that brings those blue bars over 100, for which then workers' comp will have a different feel. Next slide, please. So this is just showing, you can see in blue how our state is doing very well with our workers' comp premiums. And, those are great initiatives from our governor. Looks like the state of Utah, I think it is having same success. But what I like with this map, it's showing, look at the gray states. Those are states where there's no private workers' comp insurance. These are all state-run programs. That's very different. The state of Wyoming, which is that darker orange, they only have workers' comp for hazardous occupations. I don't know how they define that. Aside from Wyoming, Texas is interesting because Texas gives each employer the option to opt out of workers' comp. I don't know why a company would do that because they would lose their exclusive remedy. But it's just showing you there's such interstate variability with workers' comp that an injured worker in Texas is going to have a different experience than an injured worker in Illinois or an injured worker in Delaware. Next slide, please. So this is just from a legal point of view. I'm sorry, for the physicians on the legal side with this. What is your job with workers' comp? Just provide medical care to injured workers. There was a very weird situation. It was the 6th District Court in Michigan in 2010, where there were injured workers who claimed that their company was in collusion with the local doctor and the insurance company to deprive them of their workers' comp cases. It was the equation of doc plus insurance company plus employer equals RICO charges. That's right, RICO charges. The injured workers were claiming that the doc in this situation was depriving these injured workers of a state right in Michigan for workers' comp, which was the equivalent of loss of property, which would then be filed under RICO charges, which again, that's organized crime. It became a very strange case, and in the 6th District Court said to the state of Michigan, look, you don't have supremacy. You can't apply a federal RICO law on your workers' comp cases in the state of Michigan. But they were like, it's a very interesting concept. If you want to come back to us with another case, we may reconsider it further. Then that went to the Supreme Court. The Supreme Court didn't actually hear the case, but they did give an opinion. And they basically said to the 6th District Court, you should really look at this a second time. So, and ultimately on the next case that the 6th District Court had, they basically said, oh, there's no RICO involvement here. What's my point here? Don't get into trouble with insurance companies and employers. You're not doing them a favor, and you could really get yourself into a lot of trouble. There's enough of legalities in workers' comp that you don't need to create anymore. Just provide medical care. It's a knee sprain, treat the knee sprain. Don't get caught up in the other static. You may provide an opinion on causation. So these are IME cases, independent medical examiner cases. This is sort of what I did from an injured worker in New York State. The legal proof of that is 50%. It's more likely than not. It's not in criminal proceedings where they call it, above and beyond, or what they have, like where the proof has to be 100%. For a civil case such as workers' comp, it just has to be 50%. This is an important point. HIPAA does not apply to workers' comp. I'm not saying you should just distribute all the medical records for these injured workers and you want to talk to your company's attorney as well. But the fact of the matter is when these cases are adjudicated, it's an open chart. The insurance company will see it. The administrative law judge will see it. Opposing counsel will see it. Everybody who's involved in the case will see the chart. So you want to provide minimum necessary information. The form to the right is the Delaware Workers' Comp form, which I really like because they just make it plain and simple. Talk about the injured body part. Talk about your treatment plan. You can give down light duty restrictions. And the other thing is when you're talking about an injured body part, don't get fancy. I had a colleague of mine recently, for a hip sprain, she put down adductor muscle sprain strain. And I said to her, don't do that. The insurance company won't even know what you're talking about. Think about injured body parts. And then there's the disability status. If you put a worker out of work, that's temporary total disability. I'll come back to that term in a minute. Sedentary duties, temporary partial disability. The assumption with the temporary disabilities is that the injured worker is going to get back to their return. They're going to get back to their pre-injury state. But unfortunately, there's going to be injured workers where they're not. They've tried surgery, they have a failed back. This is as good as they're going to get. At that point, they're called maximum medical improvement. They're at MMI, for which the disability is now either a permanent partial disability, for which they would be good candidates for vocational rehab, for which maybe there's another career they can do. If not, it's then called permanent total disability. They're unable to fairly obtain employment. Permanent total disability does not mean they are totally medically disabled. Does that mean that they're bedridden? It just means they can't fairly compete in the job market. So a good example of that would be if you had a worker who, as a child, 3 of their fingers were amputated off their right hand at one point. They get another job, they're working a job in a warehouse, and their left hand is amputated. They're now totally disabled. They can't fairly compete in the job market. Okay, next slide, please. This is just, if you've never seen this, this is an OSHA 300 log form. Companies put these up. I don't want to go into too much detail about this form. I just want to make you aware of it. This form, safety people, when you talk to companies, that business to business relationship, safety people are very particular about how things are documented on this form. OSHA does provide a definition called first aid, where if something could be treated under first aid, it is not then going to be in step 5 as an injury or what else. So what is first aid? If a worker had to get a tetanus shot, if a worker is being treated for their ankle sprain with an over-the-counter medication, if they have a corneal foreign body where you can just remove it with the Q-tip. A big thing is laceration care. If you start to suture something, it is now recordable because OSHA now considers that to be a closure technique. OSHA prefers coverings. They prefer steri-strips, anything that covers a wound, because then that's considered first aid. So you have to when you're doing occupational medicine, you have to know how the safety people see this on their end, the work that you're doing. Because if you're putting if you have a style of medicine that's making them put stuff on their OSHA 300 form, when they sit down with their workers' comp insurance company to kind of get their premium, this document is also looked at by the insurance company. So just be aware of that. So next slide, please. And the next thing I want to show you here is that the Bureau of Labor Statistics and the Department of Labor, they ask 250,000 establishments every year to say, hey, give us your OSHA 300 logs. We want to see what's going on. And I just want to show you that what's being captured on the OSHA 300 log, on that log, 95% of it are injuries, not illnesses. So does that mean illnesses aren't happening? Does that mean a case like my worker is not happening? No, it doesn't mean that. There is a biasness on that OSHA 300 form to kind of underreport anything that's complicated because it's being filled out by non-medical people. So the interesting thing here to the right, there was a real blip on with illnesses during COVID for respiratory illnesses, which only makes sense. But the way the OSHA 300 log is capturing injury and illnesses, it's primarily capturing injuries because that's the thing that everyone seems to understand better. Next slide, please. So a couple more slides about workers' compensation. Employers, this was a great report by OSHA, adding inequality to injury, the cost of failing to protect workers on the job. By going through that report, they were able to determine it was a great report. It was the Department of Labor, Thomas Perez did a great job. Employers are negatively externalizing workers' comp as a societal cost. So if you look at the total dollar amount, employers are bearing only 21% of the workers' comp costs. Injured workers bearing about 50%, and Social Security system is bearing 20%. That means as taxpayers, we are subsidizing these employers. The state workers' comp systems, again, I kind of already told you that it's just primarily looking at injuries. However, illnesses are occurring. Workers' comp systems are inadequate venues for occupational illnesses. Only 5% of the illnesses and 1% of cancers are being captured by the workers' comp systems. So that it always has brought up the concept is, do these state workers' comp programs need more federalization? Does there need to be more federal involvement? And you may not realize this, but the federal government is involved in some aspects of state workers' comp. Black lung benefits are covered under MSHA. Asbestos benefits are actually talked about in the Affordable Care Act. World Trade Center benefits through the Zadroga Act. There's been more, I'd say, over the past 30, 40 years of the federal government taking on more occupational illnesses because the state workers' comp systems just are not. Next slide, please. So a very interesting point in our country's history, when the OSHA Act came out in 1970, there was a part of the act that said to the executive branch, we need to have an investigation in the workers' comp system. So there was congressional hearings in 1970 that produced the report to the right in 1972. And I've read the report, and this quote by Senator Javits, who's from New York, always stuck out to me. We have a responsibility as part of our constitutional duty to regulate interstate commerce, to take appropriate actions to prevent the states from competing with each other to attract new business on the basis of unjust and inhumane workers' compensation laws. That is so true, and it is still happening. A couple things to keep in mind here is that interstate commerce is only regulated by the federal government. That's in the Constitution. It's called the Commerce Clause. But here you have states tweaking their workers' comp systems to attract companies from other states. A good example, at the state of Alabama in the early 80s just slashed their workers' comp benefits to draw more business from Georgia. The report here to the right was the commission's final report. It was 2 years of hearings. And I don't know how well it shows there on the slide, but the report came out in July of 72. So if you think about your US history, what was Richard Nixon doing in the summer of 72? I think he may have been a little distracted, and he may not have paid much attention to this report because nothing really became of their findings. They gave 19 recommendations for each state to have for their workers' comp systems. These recommendations were to cover occupational illnesses. This was also for increasing the annual weekly wage from 100 to 200%, to have compulsory workers' comp systems. This went through the Nixon administration. It went to Ford. Gerald Ford actually filed up on this. There was another report called Workers' Compensation. Is there a better way? I always liked the title of that. It went into the Carter administration, where the Carter was going to make federal standards. Carter also really helped out the mining industry with MSHA. And then when the Reagan administration came along, it all went by the wayside. And unfortunately, when you read up on workers' comp and occupational medicine, each presidential administration has a kind of a different feel to it. So this was kind of a turning point with workers' comp that just didn't happen, which was very unfortunate. Next slide, please. And this is just showing kind of the same type of thing. Workers' compensation. This is from the National Academy of Social Insurance. Great publication, comes out every February. What I want you to see in the bar graph are the indemnity benefits. The cash benefits have been decreasing steadily since the early 1980s. Right now, a workers' comp case is about 50% medical, 50% indemnity, the cash benefits. Why was this happening? Because the insurance companies were saying at the state capitals in the early 80s, we're going to go out of business. We can't afford to still do, to provide workers' comp insurance in your state. And this is, just go back. Yeah, you can go one more. You can advance again. And I just wanted to show you again here, this is a table from that report, how each state does workers' comp differently. A big thing I want you to look at is you can see our state there, Delaware. Look at the temporary total disability. Weekly max is $797. Look at the District of Columbia, it's $1,521. That's a big difference. And that's, again, the maneuvering that a good workers' comp attorney can do to get your case into a different jurisdiction. Right now, the way workers' comp wages are set, it's at 66 2/3 of the average weekly wage. The average weekly wage in our state is about $1,300. So if you do 66 2/3 of that, the max that any injured worker is going to get in this state is less than $800 a week. That's not enough money. And this doesn't take into consideration, this worker is now not working. This worker could be losing, could have a second income. This worker can't be getting that money. The loss of fringe benefits, they can no longer contribute to their 401k. So again, each state does this differently. Just to let you know that the state of Iowa actually has a weekly max of $2,005. That's a big, big difference. So, we can say in this state that our premiums are decreasing for workers' comp, which is great, but we really need to do better with our average weekly wage. And again, one of the recommendations from the commission's report was to have this at 200%. So right now we're at 1,300 average weekly wage, that's 100%. Double that up to 2,600, and that's now 200%. 66 2/3 of that is a bit more of a reasonable weekly salary. Okay, next slide, please. And again, New York State does workers' comp really different because we have this New York State Occupational Health Clinic Network, which is a surtax on the workers' comp cases in the state. So we're able to capture these illnesses, such as my case. Again, speaking to the fact that each state is different, New York State had a commitment to helping out injured workers with illnesses. Next slide, please. And this is just showing references. Let me go through this real quick. Medical training, there's about 20 residency programs in the country. There's a CIQ training for the American Osteopathic College of Occupational and Preventive Medicine, CME programs for the American College of Occupational Environmental Medicine, industrial hygiene, the American College of Governmental Industrial Hygienists, ACGIH, the American Industrial Hygiene Association. I'm a member of the Delaware chapter, and we are just starting with meetings at this moment. We've had 2 meetings this year. We have 4 more scheduled for next year to kind of, let other people know about occupational health. We meet at the main campus up at DuPont in Newcastle. So if anybody's interested in more about the Delaware chapter, reach out to me. Occupational Safety, National Safety Council, American Society of Safety Professionals, labor activism. This is sort of in the spirit of Alice Hamilton, the National Council of Occupational Safety and Health. These are called COSH groups. The local one we have is in Philadelphia. That's called the Philadelphia Progressive COSH, or Philly PCOSH, I think they call it. State OSHA plan. If you want to see what a great state OSHA plan will look like, look at the states out west: California, Washington, Oregon. Again, California has a standard for ergonomics, for wildfire exposure, for heat exposure. These are standards that the federal OSHA doesn't have. CDC occupational research through NIOSH or through the Agency of Toxic Substances and Disease Registry. occupational medical clinics, which I was part of one in New York State. These are clinics that are more tasked, more academic, more tasked to look at occupational diseases. The closest AOC clinics we had in our area would be at Hopkins and Penn, and workers' compensation, the National Academy of Social Insurance, and I've used their material in this presentation. So to the next slide, please. So I just want to wrap up by talking about my case here. This is about Corian, and you may have this in your own home. Corian is a great countertop. It really had its heyday, I think, in the early 2000s. It's manufactured by DuPont. It's a man-made countertop. It's non-silica. It's composed primarily of aluminum trihydrate, which is derived from that little piece of pizza, I guess it looks like on your screen, but that's called bauxite. And bauxite is a sedimentary rock. The aluminum, it's bound with silica. It's called an aluminosilicate. And so what happens is this is mined by Alcoa. Alcoa then extracts the aluminum from the bauxite, refines it, and then prepares different compounds of it. DuPont uses aluminum trihydrate to make their Corian countertops. You'll also see aluminum trihydrate and aluminum trihydroxide. It's the same chemical. The key thing is knowing the distinction with aluminum oxide, and that's something I'll talk about later on. But Corian is great, and it's stain resistant, it's seamless, it's scratch repairable. There's all these little things on YouTube about how to repair it with sandpaper, and it's really easy to repair, but I don't know if I'd be sanding it. People do. And it's easily customized, and it's at a lower price point than silica countertops, your engineered countertops, engineered quartz, engineered granite. And it's still sold in your big box stores. Next slide, please. So this is my case. I first met him in September 2012, 48-year-old white male who was referred by his pulmonologist regarding his recent diagnosis of interstitial lung disease. He was in good health up until the summer of 2010, in which he began to notice discoloration of his fingertips and was diagnosed with Raynaud's by December 2010. By December 2011, patient developed dyspnea with everyday activities, and by the summer 2012 was diagnosed with interstitial lung disease secondary to scleroderma. Also during the summer 2012, patient began experiencing dyspnea at work and began using more sick time for medical appointments. Next slide, please. So I again saw him in September 2012. This is a table that's in our publication just to show you how awful his PFTs were. So in February 2012, his FEV1 was 1.55, his FVC is 2.2. This is a restricted pattern with a preserved ratio. The total lung capacity was 3.5 liters. The DLCO, which is the diffusion capacity for carbon monoxide, that's kind of testing for gas diffusion at the alveolar level, was low. So, and by November 2013, that's less than a little bit a year after I started working with him, these numbers have dropped even more. His TLC, which for his age, weight, and sex and height should have been about 6 liters, his TLC's total lung capacity was 2.2. Next slide, please. The other interesting thing about him was he had these interesting autoimmune labs that just never seemed to, no one could never really make straight sense of it. He had a positive ANA, which, as you know, with ANAs are very nonspecific. Positive anti-Smith antibody, which you would see with mixed connective tissue disease, Sjogren's disease, not necessarily with scleroderma. He had a positive Rho52 antibody, which is not really seen that's not seen with scleroderma. A weakly positive rheumatoid factor with negative CCP, which basically ruled out rheumatoid arthritis, an elevated ACE level, which you would see with sarcoid, and granulomatous disease. Next slide, please. So we got some CT scans, and you can kind of see it there at the top slices there on the left. You see this kind of haziness that is that's sort of like this coarse honeycombing that becomes even more noticeable the lower down you go in these slices. Next slide, please. And as you can see at the bottom one there to the right, it's just strict fibrosis. It's just honeycombed. And no wonder he had a restrictive lung pattern. I mean, he can't move air in these lungs. Next slide. So then he had a right lung wedge biopsy, and this was really important. Even though he had the elevated ACE, there was no granulomatous disease. There was adenopathy, there was fibrosis, which histologically had usual interstitial pneumonia, which is a very nonspecific finding. From an occupational medicine point of view, silicotic nodules and asbestos bodies were not identified. So that basically ruled out anything from silica or asbestos. The macrophages had an opaque and bifringent dust pattern. There was a BAL performed that was negative for fungal culture after 21 days. There was a negative acid-fast bacilli after 56 days. And one of the lymph nodes were aspirated and the nodes were benign. Next slide. And this is just from that wedge biopsy, you can see this honeycombing effect. If you think back to your histology in medical school, the alveolar unit should be these nice round circles that all kind of connect to each other. This is just a very chaotic pattern, and it has those dense pink hemoxysin areas of fibroblasts buildup. What you're seeing here on the lower left are the macrophages with the bifringent patterns. Next slide, please. Next slide. Just to go back to when we talk about interstitial lung disease, there's all these different etiologies that can define interstitial lung disease. The one you don't want to use is idiopathic interstitial lung disease, which is sort of like down at 5 o'clock. It's sort of like it's a wastebasket term. That means you've not considered anything drug-related, chemotherapy agents, amiodarone, vasculitis, different occupational things, hypersensitivity, pneumonitis, the pneumoconioses, such as silicosis, asbestosis. Again, those were not picked up on histology for this patient. Connective tissue disease, autoimmune scleroderma. But this is an old slide from the American Thoracic Society, and I always liked it because we use the term interstitial lung disease, but we don't take a step back to really get a better sense of what's causing it. Next slide, please. So in the spirit of Ramazzini, I sat him down and I said, tell me what you do for a living. And so he told me he had a 26-year history of working in cabinet production with 2 different shops. The first shop was from April of 85 to November 2009. The second shop was from February 2010 to September 2012. That was the shop he was working at when I first met him. Shop 1, there was respiratory protection, and there was no visible dust. There was no Corian use. Shop 2 had cabinetry and countertop production. And again, if you think about when you go to your big box stores and you're ordering, for countertops and, and new cabinets to go with it, you set the order there, but it goes to a local fabrication shop that does the actual work. And that's the type of shop that he worked at. They were getting contracts from the big box stores to put out, the quartz countertop, the Corian countertop with new cabinets. So obviously this was a very fast-paced environment. There was only 70 workers. There was minimal respiratory protection. He was actually a production supervisor, so he was on the floor or working in his office, but he always told me there was this white dust at the job environment, at his work environment. So next slide, please. And these are pictures he took with his phone. If you think back in 2012, that was kind of novel to take pictures with your phones. But he showed me these pictures and he was like, this is what I'm talking about. So the photo to the left, that's in the cardboard, that's a slab of Corian. And all that white dust, he was saying is Corian. In the middle photo is a table saw that has pieces of Corian on the floor, and that's his office. The mailbox slots have white dust all over. And he was like, it's like this all the time. These photos were done first thing Monday morning, so it wasn't really hazy as it should be. It had settled down over the weekend. Just to let you know, any type of dust that sits like this is potentially combustible. Combustible dust is very dangerous. All dust particles have an electrostatic charge on it, and if there's any type of ignition source, dust can explode. And if you ever hear these stories on the news about there was a sugar plant that blew up in Georgia about 10 years ago. I think like 15 workers died. It was from combustible dust. So not only is this dangerous in terms of what my worker may be inhaling, but this is kind of a fire hazard as well. Next slide, please. So if you remember, I was talking about the hazardous materials. That's standard. That's when you can ask your employer, hey, I'm working with this new chemical. What's in it? This was the MSDS sheet for Corian. And it's highlighted there that Corian is just 100%. I had no way of knowing what that meant. Now, the federal government does allow companies not to reveal trade secrets or any proprietary information. But with that said, there has to be some version of the company telling workers what's in this material. And I kind of knew Corian had some version of aluminum compounds, but I really didn't know for sure. The methyl methacrylate and the butyl acrylate, those are the binding agents that they use when they make a Corian countertop. So those were less than 1%. So I really had no way of knowing exactly what was in this countertop. I know it was called Corian, and I had an assumption it was an aluminum base primarily, but there could have been silica. Also in nature, bauxite has titanium and iron. Just didn't really know for sure. And it was a little troubling for me as I was working this case. Next slide, please. So one thing you have to think about when you're doing these types of cases, it's the question I asked there, does this make sense? Did it make sense that a 48-year-old healthy white male gets an autoimmune disease, scleroderma, and a restrictive lung defect? There's no family history of autoimmune disease. He's a former smoker, and he has GERD. Does it make sense that that type of patient is going to have scleroderma? I would really say no. Scleroderma is a very rare connective tissue disease. The U.S. incidence of 20 new cases per million with a prevalence of 276 per million. And actually, the National Scleroderma Foundation actually cites higher numbers. In terms of demographics, it's primarily a female ratio, 5-to-1, predominantly in African American females. The interesting thing is when you look at scleroderma epidemiology, it is for whatever reason in the Choctaws, I think I'm pronouncing that right, this Indian tribe in Oklahoma. It's like the highest rates in this country are in this tribe. And that's due to some haplotype in this tribe. No one really knows for sure. But if you really have an interest in studying scleroderma, this is the population to study. And that actually came up during my deposition that I had to spell out that my patient was not Native American. I mean, we're all Native American in a way, but he was not from Oklahoma. Next slide, please. So when I was thinking about this case, I was thinking, okay, I have an exposure. An exposure was going to an autoimmune disease that was going to an interstitial lung disease. What pathway could there be? Organic solvents can get you from exposure to an autoimmune disease, but in and of itself, organic solvents are not going to get you to the interstitial lung disease. But the organic solvent can get you to scleroderma, which could then cause the interstitial lung disease. Silica dust can also go across the board as well. Aluminum dust does go to interstitial lung disease, but it's not believed to have an autoimmune component to it. So a couple of little comments here. There's a lot of research about organic solvents and autoimmune diseases. If you look at the literature, I think any organic solvent has the potential in a certain patient to be a trigger for an autoimmune disease. So at this job site, they are using toluene. The particle board of cabinet material emits formaldehyde. So organic solvents, we use it in every day of our life. So it's such background that I thought about it as being a potential exposure, but I couldn't really see how that would work either. Silica dust, silica does have an autoimmune component. There's a disease called Kaplan syndrome. This is patients with rheumatoid arthritis can get a very advanced state type of silicosis. So that's a possibility. And the aluminum dust primarily gives a restrictive lung defect. So when I sat down for my depositions with the New York State Workers' Comp Board, I gave out all these possible scenarios for exposure, be that solvents, silica dust, or even aluminum dust from the Corian. But it kind of went down as being just a mixed exposure. Next slide, please. And as you see there, in January 2013, the patient did receive his case from New York State Workers' Comp for permanent total disability. So for mixed exposure, again, as I told the board, I wasn't sure if it was organic. I wasn't sure if it was silica. I wasn't even sure if it was Corian, but I did know for sure the scleroderma epidemiology, and that part did not make sense. And what I knew about the job environment up until that point, I felt it was a hazardous environment as well. In February 2013, the patient was started on Cytoxan therapy for scleroderma, and the patient started to get his SSDI. So at this point, the patient is now on Social Security, and for his scleroderma management, he's now being covered through New York State Workers' Comp, permanent total disability. It's at that point that he gave me permission to reach out to my local OSHA contact to get OSHA into this cabinet shop. He was reluctant because he wasn't too sure about the whistleblower protection. He didn't want to run the risk in such a small work environment, because there's only 70 workers, of his employer taking action against him. So he wanted to protect his job. He wanted to protect his benefits. He had children. I remember him telling me about the dental bills for his kids. He wanted to keep his benefits going. And he was concerned that if he called OSHA into this work environment too soon, he could have jeopardized everything. So by the spring of 2013, OSHA has an opening conference with the employer for a single day shop inspection. Next slide, please. And this work environment was broken down into 4 quadrants. There was quadrant 1, quadrant 2, quadrant 3, quadrant 4. Quadrant 1 was phenomenal. They were doing engineered and natural stone, which has a lot of silica to it. They were using wet methods. They're wetting down the slabs before they cut them. They have respiratory protection, and they're using dust collectors. All the other quadrants, quadrant 2 was Corian, visible white dust, such as the pictures that my patient had. They use dust filters. They're not using dust collectors. And I'll talk more about that in a minute. There's no respiratory protection. Quadrant 3, wood cabinets, no respiratory protection. Quadrant 4, wood finishing. All these areas have the dust haze except for quadrant 1. It's almost as if, had this employer done work practices similar to quadrant 1 throughout the entire shop, it would have been perfect. But for whatever reason, they only did that in quadrant 1. Next slide, please. So these were pictures that OSHA took during their inspection. So you can actually see the workers working here. To the left, you can appreciate the haziness to the work environment. And there's this old adage in industrial hygiene, never breathe air you can see. And you can just see the dustiness. In the middle slide there, picture, you can see that's a dust filter. Now, you have dust filters in your home, in your furnace, in your car. Dust filters work great, but they can't be overly caked with dust such as that filter. There's too much resistance. There's no flow pattern going through that filter. So a little bit of cakiness is always good for a filter. There's this old adage that dust filters dust better than filters filter dust, meaning a little bit of dust is good. any dust filter is at its least efficient when you first take it out of its box. So don't get in the habit, if you have contracts with an HVAC company, don't have them change out your filter every 6 months. You want to have a little bit of something going on the filter because it's actually a better filter. But this filter you see in the middle photo, this is just totally caked over. There's no airflow going through that. And what you see there is a cyclone separated. This is, if you go back to my previous slide there for a second. As I mentioned in quadrant 1, they had dust collectors, cyclone. You can advance again. No, go forward. Go, yeah, right there, stop. So that's a dust collector there. It's a cyclone. That's what they used in the first quadrant. The air comes in through the top. It's a centrifuge effect. The dust particles adhere to the side of the separator, and it just falls out. It's perfect. These things work excellent. Again, they had it in the first quadrant of the shop, but they didn't have it anywhere else. Makes no sense. Next slide, please. So when OSHA came around, they did air sampling. This is bulk sampling. So bulk sampling means that the inspectors put kind of equipment in the corner of a room and they just let it run, and the thing just then takes sample after sample. So the bulk sample was broken down into 6 different areas. Areas 1 through 3 were the Corian area. And if you look down to the metal analysis for aluminum, it's loaded at 15, 16, 17%. The bulk samples 4, 5, and 6 was in the silica area, and that had naturally 30 to 50 to 40% silica in the air from the bulk testing. But again, the workers in that area were wearing respiratory protection. Next slide, please. These are really old slides. I kind of wanted to show you what OSHA was doing: bulk and personal sampling. So personal air sampling are like those badges on the bottom. The worker wears them up near their breathing zone, and you can kind of take samples from that. There's different pumps you can use. You can see in the slides above. The one to the left are for asbestos fibers. To the right, those are Draeger counters. That's for formaldehyde, the one in black. But with that said, this was when I worked for Stony Brook. So this was work I was doing for Stony Brook. It's like 20 years old. Nowadays, these things are all digital. They're handheld. They are mounted into a charging station. It's miraculous, the technology. This is so analog, what I'm showing you. But just to kind of give you a feel of what this equipment does look like. Next slide, please. So a couple of things was happening then in 2014. The patient went to an academic center for candidacy evaluation for lung transplantation. You got a right heart cath, pulmonary hypertension was identified. He was using supplemental oxygen 2 liters per minute with exertion and not at rest. He was put on the wait list. They felt that he was too early in his disease process for a lung transplant, but they put him on a wait list. But the real big thing that happened, in terms of Corian, was this great publication in the New England Journal of Medicine. It was the first published case report on Corian dust. So next slide, please. So this was the work from Jerry Abraham from his lab in Syracuse, and this was a case report for, he was an artist, this patient, who was using Corian, and he was sculpting with it in his garage. And he had no dust mitigation going on whatsoever. And as you can see, the CT scans up top were very similar to my patient. The histology shows that honeycombing effect. On the bottom left, that's a scanning electron microscope. It's looking at inorganic compounds, and the aluminum blip is quite high. That spectroscopy to the right, this is something that comes up, and I'll explain this a bit more in another minute. It was picking up aluminum trihydroxide and aluminum oxide. But this was a great case because up until this case, the literature was not mentioning aluminum from Corian countertops. It was mentioning Corian, it was mentioning aluminum from like smelting plants, aluminum oxide. So this was actually a great case in that regard. Can you move on, please? So DuPont, the manufacturers of Corian, kind of pushed back on this case report. And they basically said, well, you don't know for sure. Mixed dust has been an issue. There's too many variables here. How can you make this claim with this case? Next slide, please. And a real interesting point was made from this toxicology team from Drexel, where again they were saying, well, you're showing the aluminum trihydrate, but how do you know the aluminum in this patient's lungs is not aluminum oxide? So as the group, Jerry Abraham's group, gave a reply, they were like, well, we really can't say for sure. It's reasonable. It was from Corian dust, aluminum trihydride. But the interesting thing says in that paragraph, in 2004, the patient and the last author independently contacted DuPont, but received no assistance. The DuPont material safety data sheet for Corian does not mention aluminum trihydrate. That was the same issue I had. I had no idea what exactly was in the Corian countertop. I knew it was an aluminum compound, but I didn't know which one. And I really liked how their reply mentioned the same point. Next slide, please. So what happened then was Jerry Abraham heard about my case and he was like, I want the biopsy material and I want to look at this further in my lab in Syracuse. So OSHA was like, fine, we'll do that. So the samples go to Jerry Abraham's lab and he sees the same pattern here on the scanning electron microscope as he did with this case in New England Journal. And the scanning electron microscope, if you look at the blips on the bottom, aluminum is the highest blip for inorganics. So next slide. So at that time, there was more talk about breathing Corian dust and the emphasis on respiratory protection. Next slide. So in November 2015, the patient had a follow-up with his transplantation center. His disease had progressed significantly by now. He was on 3 to 4 liters supplemental oxygen at rest and 8 to 10 liters per minute with exertion. His spirometry had declined further. The FVC is 1.48 liters, 37%. The right heart cath showed worsening pulmonary hypertension with elevated pulmonary arterial pressure. The echo showed decreased right ventricular function. He's slowly going to right-sided failure with impaired tricuspid valve. He was now on the wait list. Next slide. In the summer 2016, his health just became critical. He was getting chest pain, shortness of breath. In September 2016, the patient was admitted for a syncopal event. He was readmitted on 30 to 50 liters per minute high flow supplemental oxygen. I never heard of such high volumes. In October 2016, on October 3rd, he was put on ECMO. On October 13th, he was intubated. October 14th, tracheostomy. And on October 17th, he got his double lung transplant. And that's his x-ray before going in for his lung transplant. He's in florid heart failure. Next slide. And here he is about day 45 after his transplant. Everything's cleared up. His FEV1 blips up to about 2 liters. He's got maybe a little bit of fluid on the lower right, but it's just perfect. And to this day, I text him like once every year. He's doing great. These new lungs of his are working great. And just a little bit more background, this was all covered by New York State workers' comp. The insurance company had to pay for this, and it was a big price tag. So next slide, please. Then we got his explanted lungs. So up to this point, we only had the wedge biopsy. Now we had the explanted lungs. Jerry Abraham's lab in Syracuse looks at all the lung tissue, and it still shows high levels of inorganics for aluminum. Next slide. And this is just more photos from his lab. The histology, the honeycombing, the alveolar sacs are just ripped up. And again, the macrophages have this high bifringent dust load. Next slide. So in 2018, OSHA puts out its final report, the pathology report. And they say these findings of both biopsy and explanted lung 4 years later are confirmatory exposure to aluminum type particles. This type of scanning electron microscope EDS analysis cannot specifically identify the aluminum trihydroxide found in Corian versus the aluminum oxide found in abrasives. The findings are similar to what we have seen in another case with much more prolonged Corian exposure. That was the New England Journal case. Although silica particles were detected, the concentration of silica particles were only minimally above background and far below the concentration of silica particles seen in cases of recognized silicosis. So basically, that paragraph is saying we know there's aluminum in his lungs. We cannot firmly say, is it the aluminum trihydrate or aluminum trihydroxide from Corian or aluminum oxide from abrasive material? And they use abrasive material to cut Corian. So how do you know where's this aluminum coming from? So to the left is aluminum trihydroxide, and to the right is aluminum oxide. Again, this is in sandpaper. These are on grinding wheels. These are all things that they worked with in that Corian shop. So how can you know where is this coming from? So next slide. And this is the beauty of industrial hygiene. It took 2 labs with NIOSH where they simulated cutting Corian dust in a lab, and they were able to prove that the aluminum particles that were airborne from cutting Corian was not from aluminum oxide, from the abrasive material, but was from the aluminum trihydride, aluminum trihydroxide. And this is the beauty of industrial hygiene. We couldn't figure out this key question. And this was the question that DuPont was pushing back on with the New England Journal article in 2014. But these 2 great studies that came out of NIOSH, the one to the left was the lab in Cincinnati, the one to the right was the lab from West Virginia, just totally proved the point. So next slide. So this is just some basic stuff. If you're interested in learning more about any type of toxic chemical, the Agency for Toxic Substances Disease Registry, which is part of the CDC, it's free publications. You go in there and you can research any chemical, any compound you want. This is just, it almost looks like it should be cut into a pamphlet, but this is just the one on aluminum. Next slide. And that's just showing the same thing. Next slide. So that's really all that I wanted to say about my case. These are key references about Corian. And next slide. This is just some general stuff on occupational medicine. The ROM textbook is a little outdated, but it's a complete textbook. The Ledoux books that they put out by McGraw-Hill are kind of, little soft covered books, but they kind of do a good job as well. I guess in summary, I just wanted to leave you with a couple of parting points. One is we need docs being aware of occupational medicine. That's what my Corian case hopefully proves. OSHA just is not doing enough. They're not staffed enough. And every presidential term has a different slant on OSHA. And my third point is the workers' comp system. Workers' comp is not picking up these occupational illnesses. What I would like for you to think about on a day-to-day basis is to ask your patients, what type of work do you do? And if they work in any type of countertop fabrication setup, get a chest x-ray on them, because they are being exposed to very high levels of silica dust, potentially Corian dust. Get an x-ray on them. And that's all I have to say. Thank you.
Well, let me say, I was a fabulous presentation, Dr. Caddell. I mean,
Well, thank you.
A lot there. Fascinating case, good detective work.
Well, thank you,
I'm
Doc.
thankful that the transplant was successful. I thought we were going a bad direction there.
No, we weren't.
It's fabulous to hear you give this guy a call every year.
Yes.
One of the last points I have to pick up on, because I'm not asking my patients what they do, and that may have a great deal of impact on their health. So that's a nice pearl to take home for me as a primary care doc. You did an excellent overview of the workman's compensation as well. So I thank you. I'm grateful for your
Yeah,
presentation.
no, not a problem. If anyone has any questions about any of these slides, please reach out to me. But to your point, Doc, I think it's so important you ask your patients what type of work they do. I
Yeah.
think we've been lulled into a sense of safety and security because we're primarily a service sector economy. We primarily work in offices and there's no manufacturing as there was 50 years ago. But if you think about these countertop workshops, I mean, the patients that were developing silicosis 100 years ago, they were in mines. They were doing mining work. Nowadays, patients in countertop production areas are developing silicosis. If I had another hour to talk about engineered quartz countertops, those are 100% deadly. The countertops you have in your kitchen are toxic. Never ever tried it. Yes, I'm sorry, Doc.
Gee, let me tell the missus that, please. We're not replacing these at all.
Because when they do those countertops, it's engineered quartz. These are highly respirable particles of quartz. And if any of that breaks, you got very fine particles of silica wafting about. So pay attention, ask your patient that question. And if they say they are, because there's where I live in Suffolk County, here along the eastern part of the county, there's a lot of new homes. These countertops are coming from someplace.
Good. Does anyone have any questions for the good doctor?
No, I don't see any questions in the chat, but what a great presentation. Thank you, Dr. Caddell.
Well, not a problem. I hope you enjoyed that.
Very much. And we'll forward any questions that we receive via email on to you. And share your slides if you don't, if
Yeah,
with your
yeah, sure,
approval.
sure.
Terrific.
All right.
Thank
All
you.
right. Well, great. Thanks everybody for attending again. And that we're going to be welcoming you back and appreciate your helping us out with our series. And everyone have a great night, a great holiday. Enjoy.
Thank you.
See you next time.
Thank you. It was an
Thank you. Good
excellent talk. Good night.
Okay.
Thank
Bye
you.
now.
Thank you.